Okay, so after the break, we are now going to continue with the rest of the agenda for today. I'll start with Dr. Eyango on what we expect from this meeting and what we hope to go out here on Wednesday moving forward.
So, okay, thanks you, Kingsley, for giving me the floor, and welcome back for the. It's okay. I think it's okay. So thank you, Kingsley, for giving me the floor, and welcome back to the short break. For those who don't know me, I'm Sarah Yango. I'm the coordinator of the Buruli Ulcer Laboratory Network. I'm working at the Pasteur Centre in Cameroon, which is hosting the coordinating center of the Buruli Ulcer Laboratory Network. So here we are in Accra. Thank you, Kingsley, for the opportunity to organize the meeting in Accra. So the Ghanaian health authorities, negotiation authorities, and also WHO already confirmed that we are welcome here, and we can begin our meeting safely. So I'm really glad to be here with you today with an impression of having reunited a family, my family, of course. So we are really so glad to be here. I will be glad to also present, to take you through the summary of why we are here today and what we expected as outcome at the end of the meeting. But before proceeding, I would like to extend my gratitude to the organizing team for WHO, team from Nogoshi, and also the coordinating center, who ensures that we can be here today. So then my special thanks to Richard. Where is Richard? To Richard Akufo from the Nogoshi, Numfor Hyacinth from the coordinating center, and also Stephanie Jordan for WHO, but she's not there. Kingsley, I think that next time you will bring Stephanie with you. So please A round of applause for them, for the organizing team. So that said, so last meeting we had agreed for a follow-up, a list of follow-up actions to be implemented in 2023. So during this meeting, we will review all these actions and to see what we have been able to implement it so far, what are the challenges faces, and with your expertise, we will continue to discuss how we can move forward. So the vision was also of getting on board other skin entities. Tomorrow we will discuss more on the activities conducted toward the integration of other skin entities. And also we will discuss together how we can move through this introduction to the BU laboratory network to other skin entities network. So we are here, a panel of experts, a panel of founders, a panel of program manager. It is time also to discuss on communication, funding, and advocacy activities to promote this network. We are really at the turn, je crois que c'est ça qu'on dit, nous sommes à un tournant. We are at the turn, now almost 5 years since we started in 2019. Yeah, in 2019 we started the network. We have a COVID pandemic, but we continue to work hard to reach our objectives. So today we have to think, to discuss, to see how we can move forward, which activities we have to implement it, how this integration have to move forward. So we really need to share the ideas on communication, funding, and advocacy. So by the end, we also need to plan activities for next year, but also for the next coming years. So globally, for the outcome, we need to define a list of concrete activities we will agree to be carried out on the coming year. During our discussion, if it is possible, we will have a clear roadmap for transition, how to follow up action for each diseases we have to integrate, which laboratory have to supervise, how we need to implement external quality assurance for all these diseases. So we try to have a roadmap for the transition. So at the end also, one of the outcomes is also to see unidentified activities on advocacy, funding, and also communication. And we have this list of plans, agree upon next step for the network and activity for 2024. So really, thank you. That is a brief summary of what is expected. And thank you, and looking forward for a fruitful meeting. And so thank you.
Thank you, Sarah. Anybody has any questions, clarification for the objectives of the meeting and the expected outcomes? All right, I see no hands up, so thank you very much, Sarah, once more. Yeah. Now, as you have seen, everybody's name place, we have some names of partners who have supported the network since its beginning. And we are also pleased that they are all represented here. So we're going to give them the chance to say a few words about their contributions to the network. I will start with ANESBAD, and then to be followed by the American Leprosy Mission, and then Ralph Laro Foundation. So,
Okay, good morning, everyone. I am Marlene Izaguirre, and I work in the ANESBAD Foundation. I would like to start as the others, no? Thanking a lot of people that have made this possible, no? Noguchi Memorial Institute that has led us to be here for the next 3 days. All the people that have organized the meeting, that I know there is a lot of work being done that is not so easy to see, no? But we are enjoying it, and we will be enjoying it all these 3 days. And of all the people that are present, because I know it's an effort to come here and together, but we all think that it's very interesting. And it's important to take care of the people that are here in presence, but also those who will follow some of the meeting online. For us, for ANESBAD, it's a pleasure to be involved in this network because we see that it's very interesting work to be done, necessary and very important in order to deal with the skin diseases we work with. We are here eager to know more about the people that are involved in the project, more about the research work that is being done, also more about how is the things we have done during the project, and also how to look for the future. And we have made quite an effort also this year to come here because there are 3 of us present. There are people that are working in the research team. It's Ines, and Ileire is working also with the governments because we see there is a linkage there, and also myself that will try to talk to anybody who wants to talk to us and to start watching how can we deal with the integration and the work that is being done in this network. As Sarah has mentioned, we face these 3 days many challenges that we have to deal with, and we'd like to comment on some of them, no? Because for us, the integration is one of the key issues. We are trying to work this strategic planning for ANESBAD. So we understand integration in some different aspects. And for us, it's important the integration of the different diseases. So the transition from the BU-LABNET to the skin LabNet, it's very fruitful for us. I think it's very interesting. We can get some good experiences from that. But and I think jaws, leprosy, and cutaneous leishmaniasis could be the ones to start with, but we have to see how do we face them. We have another approach to integration, that is how to work with the different services of the Ministry of Health. So for us, the presence of the national programs here and the presence of the national programs in the network, it's important because I think there is a common work that is being done by the laboratories and also the governments, but we have to identify the roles and how to enrich from each other. No? That's another challenge of integration. And the third one, it would be how to integrate different stakeholders, no? And that sometimes it's not so easy because we have different views and different ways of approaching the issues, but I think that could be very interesting. And we have been doing that with the integration of new laboratories, but we have to proceed also, to think how to integrate more stakeholders. But the main focus of this network is to strengthen the capacity of the laboratories in order to do the service for the others. For that, I think we need a functional coordination center. We have to also to know how to standardize the protocols and make the quality assurance. Those are one of the main aims of these projects. and also how to share the knowledge among the different laboratories. No? And that's, for us, it's very important, no? The exchange among the laboratories and the knowledge share, also how to deal with the protocols and the reagents and all of that. Anyway, experience and the research work tell us that we have to build up step by step. We cannot do everything of a sudden. So for us, our recommendation for these 3 days is let's be ambitious, but with our feet on the ground. That means for us that we have to know better the situation of the laboratories and keep on with them also, no? Because there are different levels, there are different rhythms, and how to keep up with the rhythms of every laboratory, no? And I think one of the main things for us, the importance of this research work is that the standardizing of the procedures, the improvement of the quality of the assessment, and strengthening the capacity of the laboratories is not only good for the laboratories themselves, but is good for those who we serve, mostly the people affected and the health workers. So I think we have a nice job to be done. We should be, and we are pleased to be here. And I think I would like to congratulate you for the work being done up till now, and encourage you to keep on working in this way. Thank you.
Thank you very much, Marlene, and also for supporting this meeting. Most of the people funded here are here because also of the funding for an SVAD, for us to be able to organize this meeting on an annual basis. Now, may I call on Sandeep to say a few words about ALM contribution to the network.
Good morning, and thank you for the opportunity to gather here and to really discuss the successes and the activities we have done over the last 5 years. I would like to begin with congratulating the whole network and the members of the network for making this a success story to really talk, discuss, celebrate, and look for the way forward. I'm representing here American Lab Submissions as their Senior Director of Research and Innovation, and I have a couple of colleagues with me joining me for this meeting, Mr. Chriso Geladi, who is a research admin, and Ms. Jessica Masro on the communication side from American Lab Submissions. American Lab Submissions is a global organization serving vulnerable people affected by NTDs that cause disabilities and ongoing complications. ALM lives its mission of helping these people to be healed in body and spirit and restored to lives of dignity and hope. ALM develops and invests in innovative projects, systems, technologies, and tools that create sustainable, positive impact for people affected. We aim to accelerate the exploration and application of novel solutions to cure, care, and end high morbidity NTDs. With this vision, we look at 3 priority areas, and we have been investing in these 3 areas: reduce NTD morbidity, stop transmission and neuropathy due to leprosy, improve NTD data and health systems. Supporting the development of effective diagnostic and case detection programs for leprosy and other skin NTDs has been central to ALM strategic thinking and direction towards early detection and treatment of those infected or manifest skin NTDs. American Lab Submissions has been instrumental in providing technical and monetary support for the coordination activities of BU-LABNET over the past 5 years. I still remember the day when we all sat at the table, started thinking about forming this network. We were a large group of 3 people to begin with, 2 sitting beside me, and we thought that it will expand. It will include countries that represent the people affected, and it would be a voice for those who would like to have early and accurate diagnosis. And that's the today's meeting is an outcome of that vision and thinking. Harmonization of PCR-based diagnostic protocols for BU in endemic countries and also well-organized EQA programs are a success to celebrate together with the Coordination Center and each of the member laboratories involved in the network. Looking forward, exploring the opportunities for integrated case detection and treatment of skin entities has been on the forefront of our agenda. ALM will continue to support coordination activities of the network in a new integrated design and model, providing financial and technical support for coordination of the activities, personnel involved in the coordination, and other opportunities that arise in future. Thank you, and I once again congratulate the team for this wonderful meeting.
Thank you, Sandeep. Now I call on Estelle.
Bonjour, je vais parler en français pour donner du travail à traducteurs. Donc bonjour à tous. Je prends aujourd'hui la parole au nom de la Fondation Raoul Follereau France. Donc c'est pas vraiment l'exercice que je préfère, étant donné que je préfère plutôt être au laboratoire ou sur le terrain. Mais aujourd'hui, Monsieur Oleg Hous, qui est le président de la Fondation, m'a chargé de l'excuser car il ne pouvait pas être présent parmi nous et m'a demandé de vous transmettre ses souhaits les meilleurs pour une réunion fructueuse. Moi, je suis chercheur en microbiologie et je travaille en collaboration avec la Fondation depuis plus de 10 ans maintenant. Il faut savoir que la FRF a depuis 50 ans lutté contre la lèpre, notamment dans plusieurs pays africains, en apportant un soutien régulier à certains programmes nationaux et ministères de la Santé et des centres de santé. Elle a également soutenu plus récemment la lutte contre l'ulcère de Buruli, avec notamment le financement et la construction d'un centre de diagnostic et de traitement de l'ulcère de Buruli en 2004 au Bénin, à Pobé. Elle finance encore entièrement cet hôpital et en 2012, avec l'expertise de mon laboratoire, elle a également financé le laboratoire de biologie moléculaire, qui a permis de confirmer par PCR les patients directement dans cet hôpital. C'est donc tout naturellement qu'elle s'est engagée dans l'aventure et la création du BU-LABNET en 2019. Et du fait de sa connaissance du terrain et dans la logistique, la Fondation s'est naturellement tournée vers l'approvisionnement des réactifs et l'acheminement vers tous les laboratoires. D'ailleurs, vous devez avoir tous reçu votre petit colis contenant les réactifs pour la prochaine année. La Fondation est satisfaite aujourd'hui de voir que tout se passe bien et accueille très positivement la vision d'intégration aux autres maladies tropicales négligées à tropisme cutané. Merci.
Thank you very much, Esther. We have heard from the 3 partner organizations. If anybody has any quick question, comment, clarification, you have 1 minute to do that. Okay, I see no hands, so all is clear. All right, so as you have heard, we started as a BU-LABNET, but also things have evolved over the last 5 years. So during this meeting, we are going to also discuss how to expand or change the network to address multiple other diseases as also part of the integration vision. And I hope that all our partners and all our network groups and other supporters will support the effort to move it. Now, we would like to hear, as a host country from Ghana, also about what the situation of skin NTDs present in the country. So we'll focus on borrelia yours and then on leprosy. but I know there are others that we will be interested to hear of. I'm sure we can do so during the course of the meeting. Last week we were in the Volta Region Hall discussing cutaneous leishmaniasis, quite interesting topic. Though it's not featured here, I'm sure that during the tomorrow's discussions, cutaneous leishmaniasis will also be discussed. May I now call on Dr. Nana Kunamakote to present the BU and your situation. Thank you.
Thank you very much, Kingsley. I'm supposed to give an update of Buruli Ulcer and yours. My name is Nana Kunama Kote. The outline of my presentation is as shown here. The National Buruli Ulcer Control and Yours Eradication Program is under the Disease Control Department of the Ghana Health Service, in the Public Health Division of the Ghana Health Service. Initially, we had two programs, Buruli Ulcer Control Program and Yours Elimination Program. And in 2019, the two were merged into one program. Our objective is to eradicate yours by the end of 2030, having 0 indigenous yours cases, and then reducing Buruli ulcers, the big sizes. So we're going to increase the category 1 cases to about 70%, and also minimize the morbidity and disability associated with the two conditions. And we are also to collaborate with the research labs in the diagnosis and management of these two conditions. Our roles and key interventions are surveillance and case detection of cases. And with surveillance and case detection, we do a lot of active case search. And then we also do passive case search. And in this, we do capacity building for health staff, support them in undertaking case searches in their various communities, and also train them in how to manage the cases, and then the reporting of these cases. We also strengthen the health system by providing them with logistics, sometimes even with infrastructure. We do a lot of advocacy, communication, and resource mobilization to help, the program. Monitoring and supportive supervision is always ongoing, and we do a lot of mentoring in this. And we also provide technical support to other people, and then we collaborate with NGOs and then other ministries. Our priorities for 2022 and 2023 were capacity building for early case detection and confirmation of cases. And then, as I said, the logistic acquisition and distribution, we've had a lot of logistics. We distributed so much to the districts through the regions. And all activities have been integrated active case searching. And then our monitoring and supervision is also done in an integrated way. As I've been saying, we support the regions with logistics and also help them to carry out surveillance activities. And we had active surveillance and response. Especially with yours, we have total targeted treatment. I'm saying 15 districts because we had support from ANESVAD from 2018 to undertake this integrated activity. We are piloting the integrated activity in 15 districts. So having done the capacity building, active case search, and then mapping, having an ethnicity maps drawn, we needed to then treat these cases. So we either did targeted treatment or total community treatment. So we started with the total targeted treatment based on our resources. And so with the total targeted treatment, we just looked at the numbers of yours cases that they had. If you had 2 or more, we were going to, in fact, even if you had 1 case, we would do the targeted treatment, that is treating the index case and the contacts. And before we treated the contacts, we tested them with RDT and then DPP. If there was any positive case, we did treatment and then look for the contacts of those cases that came up. And then if you realize that we were getting a lot of cases, more than 5 or more cases in a particular community, we did total community treatment. We treated everybody in the community. And we carried out skin grafting for 17 doctors across the country. And then we also engaged media houses to develop the documentaries for us, so that we will use it to showcase what we are doing, and then for people to know what is happening, so that they will also contact us if they needed support. After having done this, this project, as I said, was supported by ANESVAD. So last 2021, 2022, we ended the project and we started developing another proposal for scaling up of these activities. So for this year, we've done a lot of work, but unfortunately, we have not validated some of the work we have done, so I didn't bring them here. But we did training, wound care trainings for some other districts that are not in the project districts. And we are also piloting the WHO scan app in the central region in 3 districts. And we are doing the piloting. We should have finished, but because of issues with the data connectivity and the app being used online or not online with internet issues, we have not been able to finish, but we are on it, and I must say the results are very encouraging. For the BU cases, from 2015 to 2017, we had ALM supporting BU, so the cases were increasing, and then ANESVAD came in. We started ANESVAD support in 2018, so you can see that it's increased. So, 2018, we had a remarkable increase because we had an intensive active case search is done in the 15 districts. 2019, they started coming down in 2020. And then in 2021, but in 2022, when the COVID went down a bit, getting to the end of 2021, we distributed the RDTs and the DPPs we had for all over the country. Around that time, ANESVAD has given us some money to support COVID, so we rode on the back of that project to train more districts, 46 more districts. So we had about 66 districts reporting on BU and yours. And so 2022, we just had a little bit, an increase in it, and it's also going down again. This year, we've had only 44 suspected cases. When it comes to BU, when you initially train people, they report all sorts of wounds to you because we need to do a little bit of monitoring supervision for them to really get the knowledge going down well. And so all the time you are with them, trying to let them know which is, anybody, they see any wound at all, and the first thing is, because you have trained them, the first thing is Buruli. And so all the time you are trying to ensure that the knowledge goes down well, so they don't report any wound at all as Buruli. So we are not getting as many as they used to report. So these are the regions that reported Buruli ulcers. And this is the regional burden of the cases, the numbers of cases that we have. These are the districts that reported PCR positive cases. And then for yours, it's the same story. And you will see that from 2015, 16, 17, we were not confirming the yours cases because at that time, we hadn't started using the RDT PCR for the district. We started the project in 2018. And with 2018, 19, 20, 22, just as we saw for Buruli, it's the same story. And so we had a lot of cases in these areas. Then we were trying to look at the DPP positive yours cases by age. And then from the graph, you can see that we are having a lot more cases, more between 60 to 70% of cases in those below 15 years. And I looked at the RDT positivity rate in the cases that we tested. And you can see that it's hovering between 10 to 20%. We did the same for DPP positivity rate in the RDT positive cases that we tested, use DPP to confirm. And these are the regions reporting DPP positive yours cases. The same regions that we have, and these are the districts. And because of the ANESVA support in 2021 that we did, the capacity building and active case study in 2022, we saw an increase in the number of districts reporting DPP. The next, this table, you can see that Western North here, in 2022, that was, over the years, they were not confirming cases because we were not actively working there. But in 2022, we went just for 2 weeks to do some case searches. Somebody was doing a PhD study, so we went there. And within a few days, just 2 weeks, we were able to get 150 DPP positive cases. And then this year, we also had an active case search there. And they are reporting 152 cases. I must say that it's interesting to note that when we were drawing up the proposal for the 2018, the ANESVA support, Western North did not feature. But when you start working, some districts become interested and they also want to do something. So we had a few cases, sporadic cases here and there. So based on the few cases they reported, we decided to go and do the project there. And knowing the climate, and the topography too, we were suspecting that we were going to get a lot of cases. And we were proved right. So as I speak, we are trying to do the mapping. And then next week, we are visiting them to finish with the mapping and start with the either total targeted treatment or total community treatment, depending on the cases that we find. And so some of the activities we did with the total targeted treatment for last year, we were able to treat 4,383 cases. In fact, and the contact case ratio was 8.2. We needed to get 10, minimum of 10. But what happened was a lot of the communities are hamlets. So you get in there, husband, wife, and maybe some 2 children. You treat the children, and you can't get any more contacts. And so for that particular, those areas, we had very low contact cases, but some we had a lot. But we ended up with an average of 8.2, which is not bad. These are some of the pictures. And then based on the TTT that we did the total community treatment. And for this one, if it was a normal MDA, we were going to treat, we were going to, for this is the total community treatment that was done. After this, we did a coverage survey. So with the coverage survey, under normal circumstances, we are going to manage 30 enumerated areas. That is the normal thing to do. But I must say some of these communities, we could not even get the 30 enumeration areas. So we treated we did a coverage survey for all of them, all the communities, because we were not going to get the 30 enumerated area, because if it's a district, you randomly pick, they pick an area for you, then you do the survey. This one, it wasn't like that. So wherever they treated cases, we did the coverage survey, and this was what we had. And it wasn't unexpected. We expected these figures. And I must say it was only one district, that had below 80%. With the therapeutic coverages, you are supposed to have not less than 80. So if you have 90%, it's okay. But they had 67%. And then subsequently, we went there to treat those we couldn't treat. So these are pictures of the total community treatment. And they also train the training for the skin grafting. These were the facilities that the trainings were done. One in the Central Region, Ankafo General Hospital, and Sawam Government Hospital, and the Tekwashin Memorial Hospital. We did that so that we could get more doctors to train. And so we trained the doctors in those facilities that we had the training, in addition to those that were invited for the trainings. Now, these are pictures of some of the training pictures. And these are the documentaries that were developed. And you can put this one on the platform so that anybody who wants to watch them can watch them. And then we had Daily Graphic, one of our newspapers, major newspapers in Ghana here. This is a picture of it. And then, as usual, the challenges that we have in settings like this. There's very insufficient knowledge of the disease among both health workers and the general public. And we try to build capacity of health workers, and then also embark on trying to change their behaviors, and also giving knowledge to the people. We have late reporting and under-reporting of cases, because for some of the districts, they don't even have any knowledge about the disease. Not any knowledge, but after school, you only detect what you have, you know. And they are not able to detect them, though they have them with them. And so we try and build capacity, and we help them with the social mobilization. And we also have silent districts and regions. In as much as they have the knowledge and everything, once they don't have the resources to embark on an active case search, and patients are also not reporting because of the myths around some of these conditions, they become silent. And then there's data inconsistencies. For some time now, we've been trying to build capacity, doing monitoring supervision, mentoring them to ensure that we have complete data. And then the usual lack of funding. And our priorities and way forward for this year was proposal for scaling up of our activities. We developed integrated guidelines in the diagnosis of skin entities for front health workers, integrated capacity building, we do it. Now our capacity building on BU, leprosy, yours, CL, and the management of LF. And then we do integrated case finding and management, advocacy and communication, monitoring, supportive supervision, and even evaluation of our interventions. We do it in an integrated way. And then we also do skin entity research. These are some of the things we are trying to increase in the work, enhance them in whatever we are doing. So we have pictures here. We had the last year the Director General of an expert visiting. And these are pictures of some of our review meetings, a stakeholder meeting with the regional directors and the ICC chair, all the stakeholders here. And then last year, an expert supported us with acquisition of some motorbikes, vests, and then some printers and scanners. So these are some of the motorbikes we are sharing. And then we are sharing some of the wound care activities we do in the communities. And then with the app, application of the app, some of the planning and coordination meeting and the training, these are pictures of some of them. These are the trainings. These are community-based volunteers that we train for the app. And so on that note, I want to say a very big thank you to everybody.
Thank you very much for the comprehensive overview of BU and yours activities in Ghana. We will move on to hear about leprosy, and after that we can take a few questions. May I call on Dr. Kwao?
Good afternoon. Also, still morning. Good morning. And I'll follow on from Dr. Kote's presentation to talk about leprosy in Ghana. I'm the program manager for leprosy within the Ghana Health Service. I'll start by giving a profile of the program with our mandate, the plans within which we work, and our priorities for 2023. Talk about a few key activities we've carried out. Look at the epidemiological trends, some case detection and contact tracing trends. Look at challenges and remedies, and then some conclusions. The Ghana Leprosy Service is the oldest program in Ghana and transitioned into the National Leprosy Control Program, started in 1950 by the colonial government. And the primary aim was to develop and implement policies and programs to reduce the transmission of leprosy as well as its associated disabilities. And in recent times, we are trying to focus our activities on these two main aspects. Since the early 1990s, we've had integration of the leprosy services into the general health system. We used to have about 4 leprosy hospitals, but now we operate mainly from the Ankafo Leprosy General Hospital, which has retained the headquarters status. The program manager sits in the reporting to the Director of Public Health, but also to the Regional Director, Central Region. And there is a huge hospital infrastructure that supports the work of the leprosy program. We have P&O sheds, rehabilitation staff, and it's a skin specialist facility that sees about 37% of its outpatient attendance being skin cases. We diagnose 10% of our skin leprosy cases in the country in this facility. We are working with the WHO 2030 target for leprosy, the global leprosy strategy. And in terms of the numbers, based on the 2020 baseline, what it means is that we expect that by 2030, we'll have about 78 new cases annually. Our rate per million of new cases with G2D will be down to 0.08. And we are hoping that we can achieve 0 child cases, at least before, not interrupt transmission, but at least get 0 child cases by the end of 2030. This is our roadmap developed with the support of Global Partnership for Zero Leprosy. And you would realize that one of the key activities we wanted to do by 2022 was to have a pilot SDR PEP project initiated. This we did do with the support of American Leprosy Missions, and we've gone ahead to scale that up to 4 other regions, still with American Leprosy Mission support and Global Partnership Zero Leprosy seed funding. This is our Zero Leprosy Action Plan 2021 to 2030, also developed with the support of the Global Partnership for Zero Leprosy. And activities, or the key activities, have been organized along the 4 main pillars of the global leprosy strategy, which are to increase country ownership, scale up leprosy prevention and active case detection, manage leprosy and its complications, and combat stigma. We are working in all these areas, but in 2023, as I said in my very first slide, we are focusing on reducing transmission and managing disabilities. These are our priorities for 2023: high-level advocacy and raising public awareness. We want people to know about the disease and present early, improve program management efficiency and coordination, build capacity of healthcare workers. Like BU and yours, we require continuous capacity building of healthcare workers in order to be able to diagnose the cases early. And then to scale up the contact tracing and SDR PEP implementation in Ghana. In Ghana, we have identified SDR PEP to be one of the new interventions with some evidence backing it, and we feel scaling it up would go a long way to help us learn and then also bring down transmission. We want to enhance digitization and strengthen our disability management. In fact, ANESVET Foundation has been really supportive in this regard, in supporting us with a project we call FitPad for PALS, which focuses on the MMDP aspects of leprosy. These are some of the key activities undertaken. We celebrated the World Leprosy Day with a well-known figure in the country, Father Campbell, and the Vice President was there to give his support for leprosy. The same Vice President has championed the registration of about 300 persons affected by leprosy onto what we call the LEAP this year. It means that they also get enrollment onto the National Health Insurance Scheme without paying the premium. We've done media engagement activities in all the 16 regions using community information centers, radios, TV station visits, and then the regular monitoring activities within the FitPad for PALS project, and then also for the scaling up of contact tracing in the 4 regions. Thanks to ANESVET support again, we have finalized a guideline for MMDP, and this integrates brucellosa, leprosy, and the NLF as signature conditions. Borreliosa for large ulcers, skin entities causing large ulcers, leprosy for diseases causing neuropathy, and LF for diseases causing limb or body swellings. And we have been able to successfully extend the contact tracing to the 4 regions. And from next month, with ALM support, we are doing routine SDR-PEP implementation in not just those 4 regions, but the 2 others that did the initial pilot. Now let's look at the trends. Our case numbers have progressively come down steadily, both the new cases detected and the number of new cases on register at the end of the month. If you draw a line through the last 6-7 years, it will almost be like a flat line, but there have been fluctuations. In 2018, 2019, because of the same UNSVET supported project, we did some active case searches. Our case finding went up a bit. During COVID years, we realized that we did go down slightly, and in very, very slight, but when we look at the data, we feel that we went down, and we've come back up in 2022. We managed to bring down grade 2 disability, which is the red line, to about 5.4% in 2019, but also during the COVID years, we seem to have lost the progress we made, but then in 2022, it has started to come down, and hope that with the reopening of the health system, we can find cases earlier. 13% for grade 2 disability proportion is too high. It points to late diagnosis, and we need to find a way of increasing, reducing the delay in diagnosis. And the laboratory support would be definitely helpful in that, because about 10% of cases, the clinical diagnosis may not be able to pick up leprosy. I bring this to highlight what the thinking, or what the plan is, or what the framework is within the leprosy elimination agenda. We are now looking at interrupting leprosy transmission and then going on to eliminate disease. So we all know that until 2000, we're working to eliminate leprosy as a public health problem. That has not been thrown away. Let's consider that like a stop within the journey. Now, once countries have reached that, we need to interrupt transmission, and that is seen as no new autochthonous cases for 3 consecutive years in for 5 years. Sorry. No new autochthonous cases in children for 5 years, after which you need to have another 3 years without 0 cases to reach the elimination phase, after which there's a post-elimination phase where you can detect sporadic cases, and then after about 10 years, then you can be verified as having eliminated the disease. Now, at this phase, would need some submission of dossier, some verification by an external team to make sure that the country has reached that status. So we've started also trying to look at the districts with this in mind. And so when we look at our districts, as of the end of 2022, 39 districts have reported child cases in the last 5 years. Now, this is based on largely passively detected data. So that's why we've not gone in to do any transmission assessment survey. This is just based on the routine data we have. So we can say that 39 districts still have ongoing transmission. The reverse doesn't necessarily apply to the other districts, because this is passively detected cases. Now, what 0 child cases within 0 new district reporting child. So 0 child cases 39, there's something I wanted to show here. Okay, it's not there. Okay, so 39 districts have reported child cases in the last 5 years, and when it comes to the elimination of disease, 195 districts have reported leprosy cases in the last 5 years. So all regions are reporting leprosy cases. Here, we are looking at the regional case detection trends. This is why I say that in between 2020 and 2021, we saw a lot of the regions attaining green status, which means that the numbers were going down. But you realize that in 2022, we have the most reds, which means that the number of cases they were detected went up. And that's why we feel that there was a recovery, pretty much the same thing has occurred globally, but at a much, much smaller scale. You have some regions going from about 3 cases to about 19 in that same year. Now, when we look at the child cases, we realize that it's again not all the regions, but we're talking about Ashanti region, Central region, Eastern region, Northeast region, Northern region, Upper West region, and then the Western region. And when we look at grade 2 disability, we realize that although the problem is big at the national level, it's actually about 6-7 regions that are having this problem, and therefore it allows us to be able to target those regions better. Again, those regions in the MMDP project are going to get extra attention because they have more patients with disability. Now, this is data on the routine contact tracing. We've not attempted to integrate the MARPEP and then the pilot SDRPEP projects into this data. What you realize is that routinely, based on the number of cases and their contacts and the contact screen, we are having a very low case contact ratio, which we need to increase. It's only one region, OT region, that actually crosses the 10:1, which we chose because although in our guidelines we say 40:1 for SDRPEP implementation, in assessing the regions, we use 10:1 because yours is also using the same 10:1, so that there's no confusion at that level. But then it tells you that the case contact ratios are very low and we need to drive them up. Fortunately, within the pilot projects, we've been able to achieve about 19 in the first one. And in some regions in the second scale up, we are achieving well over 20. Again, if we look, yes, so it's the same thing across the low contact case ratio. Also, a lot of patients are not having contact tracing applied. A lot of reds, okay, very few greens. So this really tells us the magnitude of the problem outside those SDRPEP regions, and that is what we are now going to seek to improve as we enter this phase where we are doing the routine SDRPEP implementation. What are our challenges? Low capacity in case detection and case management. I think Dr. Kote also spoke to that. And we are taking advantage of collaborative projects to train the frontline healthcare workers to suspect. Also, data issues are also being faced, and we are taking steps to engage the health managers at the various levels to have owned the data and strengthen data validation, and include KPIs for leprosy and other NTDs. For those managers, it drives the system to ensure that the data is being taken seriously. Then, of course, the weak MMDP and rehabilitation services, I already mentioned that we have newly developed training models. There's ongoing development of facilities at Anchorfoot. And the whole idea is that the health system will funnel up patients who require advanced care to this center. But then at the in the various regions and districts, you have people that can take care of patients at that level. Then also to strengthen the regional level coordination, we want to resume our coordination meetings and also start training the newly introduced field technicians and technical officers in the field over the last 2-3 years during the COVID pandemic. Majority of cases may not be benefiting from the clinical pathway, and we are training clinicians to own. Normally they tend to refer the patients to the public health system. So we want them to be taken care of in the facilities where they would normally get care. So we are working going forward to improve our coverages, our data quality, as we now integrate contact tracing into our routine home visits. It's part of the progressive scale-up of the implementation of leprosy chemoprophylaxis. We have also had the regions designate facilities at slit skin smear sites, and also for MMDP rehab care. As I said, we want to decentralize this care. We need to be testing about 10% of our cases for antimicrobial resistance to the leprosy agents, and we are not doing that. But the first step is to make sure that we bring back our capacity for doing slit skin smear, and we're doing that from the regional centers. I showed the map showing the status of various districts, but now with the elimination guidelines released, we now have to go in and now look at doing a formal transmission assessment survey for districts that may feel that may have achieved any of the milestone targets. Now, beyond all these, we believe that it is important that we mainstream leprosy and NTD interventions into regular health pathways to optimize efficiency. An example is our support for, the NTD program has recently developed an updated version of the home visit register, which has NTD elements. So now community health nurses going home routinely can be screening and looking for NTDs. These are some of the interventions that we believe would help us going forward in the long run. I'd like to say thank you to everyone for listening, but also to these partners and various stakeholders for their support for leprosy work. Thank you.
All right, thank you, Dr. Akwao. So, any questions for Dr. Akwao and Dr. Korte on the skin NTD situation in Ghana? Okay. All right. Augustine, then Agana, please.
Okay. I speak in French. Félicitations à tous les deux présentateurs du Ghana. Le Ghana évolue très bien et bien organisé, mais j'ai deux préoccupations par rapport au mycétome. Est-ce que dans leur plan stratégique, ils ont dû inclure les mycétomes, parce que ALM et nous tous, nous sommes en train de prôner pour l'intégration, et ici présent, ça fait la deuxième fois que l'équipe mycétome participe dans ce réseau. Et dans le plan stratégique, l'OMS a poussé que tous les pays jettent un coup d'œil sur la situation du mycétome dans leur pays. Est-ce qu'ils en ont tenu compte? Ça, c'est la première chose. Deuxième chose, les recherches actives, que ce soit pour le mycétome, que ce soit pour la lèpre, est-ce qu'ils ont les outils de sensibilisation par rapport au mycétome pour effectivement faire voir que les agents de terrain puissent penser à cette nouvelle maladie? Parce que nous savons que le plus grand problème actuel, c'est l'ignorance du mycétome effectivement dans les différents pays. Donc nous voulons profiter pour voir qu'est-ce qui se passe au Ghana par rapport à cela. Merci.
do you want to respond, presenters from Ghana? Augustine, now.
I will try to be clear. WHO asked all countries to involve Mycetoma in the master plan. Did Ghana do it or not? And for integration of skin entities, Mycetoma must be one of the diseases that be closely to Brûlé ulcer and leprosy. Did you take the opportunity to, when you are doing active screening, to think about it? Did you have some material for communication? Because we know the first step where we have to start is to give awareness of this disease that is very, very neglected and not known in many countries. What is the situation for Ghana, please?
Thank you very much. For mycetoma, from my own experience, after attending the WHO meeting for the first time, I realized I had seen about two cases that looked like mycetoma. But so from that meeting, I started adding them to our presentation, my presentations when I'm doing the presentation for BU. So after I've done everything, I show pictures of mycetoma and a little bit of it, so that in case we find some, we will report. So far, nobody has reported any such lesions. When we do the case, we have platforms for all the districts and they send the pictures. I've not seen anything that looks like mycetoma. Recently, I saw a lesion and we are discussing it. Maybe I'll put it on the platform for people to maybe provide ideas what it is. I sitting here, I don't know what it is. So thank you very much.
In the master plan listed as mycetoma, but in our master plan, it identifies the integrated skin and TD strategy as an entry point for all potential skin cases. And like Dr. Kote said, we have platforms for all the regions, some of the intervention districts, where then we are able to make input when they put the pictures on. Yes.
Dr. Agana, please.
Thank you very much. I wish I were the first to ask because my question is rather selfish. I have lost a small bag. I think I was eating too much and I forgot it somewhere. So if you have seen a small bag, very small like this, I can't find my bag, please. It's black, blue black, you know. I've got a few documents inside it. Yeah, then my next thing, thank you very much, Dr. Kote and Dr. Kwa for those brilliant presentations. And the first thing has to do with yours. I was talking with one Dr. Akufo of Noguchi, and he showed some data that indicated that PCR for detecting yours detected several more cases than DPP. So DPP detected very few, and the same sample, I think he mentioned over 100 cases. DPP detected not up to 10, but PCR detected up to 60. So I think I can see Michael Marks here. If he has done some more work on the DPP area. I know DPP had some slight issues at the beginning. So let's take a look at that and see how. Then my friend Dr. Ablode is sitting right here next to me. He's also shown some data, and when we're looking at that data on Bruley ulcer, clearly, the more cases that were, or samples that were presented by the districts, the more positive PCRs you saw. So my question is, are we not looking well, or really, that the Bruley ulcer cases are diminishing? Once we don't know the mode of transmission, if you detect 50 cases and tomorrow another 50 cases are infected, you don't know, you cannot really say that you are being totally effective. So maybe looking more and trying to take more samples, training people to, take better samples and sending more samples, then we can only say that we are being effective in trying to reach out and diagnose BU cases. But again, my bag, please, anybody, my bag. Thank you very much.
Thank you, Dr. Agana. I'm sure you'll find your bag. I just hope that you don't have millions of dollars in the bag. I presume your remarks were contributions, not questions. I hope the program managers have noted. Also, the issue of more PCR detected in your slight lesions and vice versa. I think from the presentations I was going to highlight that we are here for PCR work, and I wanted to see also more about sample collection and transmission to the labs for confirmation. I saw some data on that, but I don't know how this is done, whether it's routine or occasional collection and transmission of samples. But we'll have time to discuss that as well. Michael, in case you would like to comment on the yours part, please feel free to do so.
Michael Marks, London School. I'll answer Agana's question first. So, I mean, it's well established that PCR is more sensitive than serology because it takes 2 to 4 weeks to mount an antibody response. In every study done, you will always find some cases by PCR that are not detected by DPP. So I think that's the first issue. The second thing is we have had some reports at the most recent WHO STAG that some of the batches of DPP have not been performing as well. So in Papua New Guinea, we have also had many examples where it seems like the DPP has not been performing as well, and that possibly that is due to a batch production issue. And I know that Kingsley has raised that with ChemBio, who make the kit. So that's, I guess, in response to Agana. My comment really is mostly in response to Nana's presentation, which I think it just highlights that making decisions on the basis of, and this is not a criticism of Ghana, I think this is true in every country in the region and it reflects funding, but when we are making decisions about what to do on the basis of passive reported data, this is extremely unreliable, and Nana showed that very nicely when she said we didn't include Northwest in our proposal to Anasvad because we didn't think that there were many cases, but actually when we went and did activities there, we found many, many cases. So I think we just need to be very cautious when we are interpreting routine passive data about the presence or absence of disease, or even deciding where to deliver interventions. You know, which village should we do mass treatment in, which should we not do? Unless we have really good quality, systematic surveillance, which we cannot get from passive surveillance alone, we will always be making not the wrong decision, but not the most informed decision. So we need to think about how to move from routine reporting at health facilities, which is clearly not reliable, to countrywide issues. And I know Sarah and I, we've had the same issue in Cameroon and projects where we have gone to many places where we thought that would be yours on the basis of routine reporting and found no cases or tiny numbers. So we really need to strengthen that, move away from passive and towards active surveillance.
Thank you, Michael. Yes. I was also expecting Dr. Kunama to show us not only activity photos of the yaws, particularly in the area that they found more cases, but also clinical photos. I hope that she will be able to complement her presentation with a set of slides on the clinical cases so that we can also do some evaluation of what kind of cases they are seeing. Is there anybody stand up again? Dr. Oh, okay. Sunday, please. After that, Dr. Barigi.
Question to Dr. Benedict. Wow. On the leprosy diagnosis, is there any laboratory support for confirmatory diagnosis of leprosy in the country? Are you sending any samples for PCR? And also on the drug resistance determination, is there any plans for the laboratory-based confirmation? How?
Thank you for your question. Usually, okay, so we have not done any confirmation using PCR, like of any resistance in the country. What we have done, I think 2 years ago, was to collaborate with the Bernard Notch Institute of Tropical Medicine and then the reference laboratory in Germany for TB to test some suspected cases, like retreatment cases that we wanted to be sure there was no resistance in. About 3 samples from 3 different patients were sent for resistance. In fact, one patient had no evidence of leprosy protein, PCR. So, we have subsequently, between BNI and then the National Public Health Reference Lab, tried to incorporate antimicrobial resistance monitoring within specific grants, proposal for research that we have written. 2 in all, I think, but both have not been successful. We are planning to use that to sort of kickstart that aspect of what we should be doing. But we are also going ahead to make sure that we build capacity for slit skin smear testing, which would be the first step. Because anybody who has 2 class or more protocol in the country is supposed to have that antimicrobial resistance test done. Thank you.
Okay, Dr. Barigi, then Professor Phillips.
Okay, thank you. First of all, I want to thank Ghana team for the great job. And I have one question for the BU program manager regarding I want to know, did you use the BU clinical score? Because we can see clearly that this year, only 5 out of 44 have been confirmed by PCR. This means only 10%. So did you use the BU clinical score? The second question is for Dr. Benedict. And again, congratulations, I can see that you have already started piloting the leprosy eliminating tool. That is a good. And also you have conducted some contact tracing. But what we miss, we don't see how many leprosy cases or over skin disease have been detected during this contact tracing. Thank you.
Okay. Can you respond first before I ask Professor Phillips?
Hello, okay. We do use the clinical score. We do use it. They use it in the districts, and then they send it to the labs. And unfortunately, that's what we are getting. Just two. In fact, we have only 3. As at last month, we had 3 positives, but we used the forms. Thank you. Personally, my own opinion, I think maybe we are getting a lot of negative because of the skill in taking the specimen. Because those who were taking the specimens for us some years back have all retired. We have new people taking it. So it's one of the things we want to do with the next set of trainings, to train people in specimen taking. Thank you very much.
Any money in the bag, thanks to my persistence, you give me 10%, yeah?
Concerning the outcomes of the pilots, they are within the detailed reports from the various regions on that. So I can show that to you later. I just presented the routine data on contact tracing to show what we need to do as a health system to improve that aspect. Thank you.
Okay, Dr. Kwal, thank you very much for your presentation. Just clarification. When I look at the data you presented, the rates were increasing, particularly in 2022. And I was wondering whether it is not because of an increase in activity that year that contributed to the rates, or baseline, is it the same level of activity across the years? Because maybe the cases have been there, just that when the activities went up, then you saw more rates coming in that area. I was just wondering because of the NextVAD project, probably. Thank you.
Thank you for your question. So when you look at the data I presented, you would see that what we saw in 2022 is similar to what happened in 2018 and 2019 when the NSVET project started, you know. But looking at what has happened between 2019 and 2022, we think that it is more due to what was happening during the pandemic years, suppressing activities, right, that led to what we saw between 2020 and 2021. And in 2022, it is more likely a recovery. We are finding more cases. We are finding a lot of them with grade 2 disability. Yes, we're finding them slightly better earlier than 2021. But those increases should not be interpreted as the program getting worse, like the numbers of cases rising. It's more a case of us finding cases that may have been missed. Yes.
Okay. Any more questions? Dr. Fanzu.
Merci beaucoup pour la parole. Ma préoccupation va dans le sens aussi de la question de Dr. Yves. Ça s'adresse à Dr. Nana. J'avais vu la diapositive sur les nombres de cas suspectés et la confirmation par PCR. Okay. Donc la question va dans le sens de la préoccupation par rapport à la confirmation diagnostique. Donc le nombre de cas suspectés est élevé, mais peu sont confirmés par la PCR. Alors la préoccupation, est-ce que vous avez des explications? Vous avez parlé de la qualité des prélèvements, mais le nombre élevé de cas suspectés, si ce n'est pas ulcère de Buruli, il s'agit de quoi? Parce que c'est quand même un effort qui est fait de suspecter beaucoup de cas. On envoie les échantillons au labo, c'est aussi la charge de travail au laboratoire, mais peu sont confirmés Buruli. Mais s'ils ne sont pas confirmés, il s'agit de quelle autre maladie? Je ne sais pas si vous avez des explications par rapport à ça.
Is it okay for you?
Thank you very much. If I understood you well, you said we have a lot of suspected cases, but few confirmed ones. In fact, all the cases we suspect, they are put on platforms, and then they take the samples, they are sent to the labs. So all suspected cases, samples are sent to the labs. And what comes positive is what you see. What we do is we ensure that they are managed. If it's not buruli, we look for whatever it is, and then they are managed. I must tell you that more than 90% of the wounds get healed. Only, I'm just giving an update on BU. I'm not here to give anything on wounds and all those things. That's why I didn't show pictures of that. But I can assure you, we treat all those cases, and then we manage the wounds for them to heal successfully. Thank you very much. Those who, some of them, the wounds are so big, once they get to a stage where we can graft, we do grafting for them. And so I would say even the 90% is about those who do normal wound dressing. The few of them have grafting. And that's what we do. Thank you very much.
Kingsley is coming, so I continue to chair the session by Kingsley. So thank you very much, the Ghanaian team, for the presentation. So for leprosy, what I would like to raise is that tomorrow we will have a presentation on what we are doing for integration and also what we are currently doing for lab and antimicrobial resistance. So we will continue the discussion to see how this could be integrated, and that you can also have testing here instead of sending it abroad. Okay, thank you. So we are on time and we are moving. We are moving to the next presentation. Dr. Isra, who will give the talk on the role of laboratory. I have the text in French. So the role of laboratory in achieving the NTD roadmap for 2021 activities of the WHO Diagnostic and Technical Advisory Group. So Dr. Isra, you have the floor.
It must be here. Okay. Thank you. Sorry. Thank you for the introduction. And hello, everybody else. Thanks very much, the organizers, for inviting me to provide this overview of the diagnostics needs to address 2030 targets on NTDs, especially on skin NTDs, and a little bit of the work we are doing at WHO DTAC. I think we all will agree that the diagnostics are essential to address public health issues on a sustainable manner. Diagnostics can be patients, communities, and program and work to support activities in these regards on different ways. Regarding neglected tropical diseases, we will also agree that diagnostics are key for detection, management, and surveillance activities, as well as to contribute to other programmatic activities such as distribution of disease, mapping of disease, monitoring, evaluation, elimination, interruption of transmission, and certificate elimination. For all this, we need accurate diagnostics. Fortunately, for those of us working a little bit on this, diagnostics are gaining momentum. A few years ago, there was a first release of essential diagnostic list, and very soon it started to include diagnostic tests for neglected tropical diseases. This essential diagnostic list, similar to the essential medicine list, it's addressing an important issue in terms of public health. If we look at, or if we know that a big number of decisions in the healthcare system are influenced by the access to in vitro diagnostic tests. But for these type of tools, a very little amount of money is dedicated to improve or to provide new tools for other diseases. And if we look with more detail at the low and middle income countries, we will see that access to proper diagnostics is very scarce, and many occasions reaching just 1% of the population. And this has important consequences. First, incorrect diagnosis, which is huge, make feel health workers powerless, and patients are not managed properly, or they don't receive the treatment they need. Following with this momentum, it was the launch of WHO roadmap for neglected tropical diseases, which consider diagnostics as one of the main pillars for this roadmap. Diagnostics, according to the roadmap for entities, help accelerating elimination as they are informed strategies. They help reducing morbidity because they enable early treatment of patients, or maybe not treat patients in case there are treatments that can cause adverse effects. Also, proper use of diagnostics help in reducing and optimizing cost of the programs, pharma companies and donors, allows effective target treatment, and they can help in reducing years of mass drug administration if properly used. Of course, they are also applicable to monitoring, evaluation, and surveillance activities. But as part of this exercise of the roadmap for neglected tropical diseases, there was kind of a way of trying to understand which were the gaps and priority for entities, and also, of course, for skin entities, which is what brings us here today. These diseases are mainly diagnosed on clinical grounds, and this is a very important aspect. To a lesser extent, we can use microscopy across many of the diseases, and if we have the methods developed or implemented, of course, PCR and RDTs could also be used. But it is more or less this arsenal of approaches that we have to use, and we have to try to improve to address these main gaps found for skin entities, which are the need to maintain and strengthen the clinical diagnosis, especially when we are moving from vertical to cross-cutting programs. Try to develop RDTs that can be used at the primary healthcare and the community level to detect suspected cases, confirm population as risk. Also, ideally, tests that allow us identifying viable pathogens to inform us when to stop treatment, like in cases such as mycetoma, for example, and also diagnostics that allow differential diagnosis and assessing drug resistance and drug sensitivity profiles. Of course, we will need to work out, and this I think will appear many times during this meeting, the common approaches for sample collection, sample processing, and ideally go beyond the patients, reach the communities, and develop tools that can be implemented at the population level. So when we are talking now more on integration, because we are working on skin entities, a number of challenges will need to be addressed. For example, new training packages will need to be developed, like a basic dermatology training that goes beyond the vertical programs, because now frontline health workers should address a different number of diseases. But also we will need to work on how to use and evaluate the new diagnostic tests to be developed, and also mobile phone applications, the use of artificial intelligence in diagnosis, etc. Technical support will always be required, and very important, and not always consider access, logistics, supply chain, etc. We will need to work together on advocacy and fundraising, and also on promoting country ownership. And regarding implementation, this is something that we can work very hard in developing the best diagnostic tools, but we may always find barriers for implementation, and this will need to be addressed. But when we think about diagnostics and NTDs, most of the time we are thinking on rapid tests, we are thinking on simple tests that address the assure and more recently reassure criteria. So tests that should be affordable, sensitive, specific, user-friendly, rapid and robust, equipment-free, and deliverable to the end user. And more recently, they also have ideally to address real-time connectivity and ease of specimen collection. This is possible for RDTs, but as said before, if we are talking about integration and integrated diagnostics, at this moment, we will need to think a bit more complex tools like multiplex platforms that allow detecting different pathogens, as well as some of these pathogen traits like resistance, drug resistant or drug sensitivity profiles. So ideally, we should be working on identifying biomarkers that can be used in a similar manner, like common sample processing approaches, etc., and develop a multiplex platform for detection. This will enable differential diagnosis and mapping conformity of different diseases in a given context, but we can also take advantage of technologies which are currently here and try to leverage the power working together using shared platforms, shared technologies, and I'm sure we're gonna hear a lot about this in the meeting, right? But once we try to address these challenges or think about how we should be approaching to diagnostics, we must bear in mind that traditionally the process of developing diagnostics has gone through a not very easy journey. It is said that there are 3 valleys of death in the process of diagnostic development, and it is important to address this in a targeted manner. They say that up to 40% of the ideas fail in the valley that goes from concept to product development. This is because there is not enough scientific or technical understanding, or because we don't understand well the use case or with the market in which we want to introduce these tools. Second valley of death is between product development and commercialization. We don't understand the regulatory process. We don't understand how we're going to scale up the project in order to have impact. And the third valley of death is the one that goes from commercialization to adoption. We have worked very hard in developing a very nice tool. We have shown it works very well, but once we have shown everything, we are not able to make it. We have not worked in advance with countries, we have not worked in advance with the companies, we have not worked in advance with the systems. Sorry. So to work on this a little bit better, we will need a change of paradigm. Traditionally, we have been working like in 2 different spaces. On one hand, the basic and applied research, a focus or maybe led by research organizations. On the other hand, the implementation aspect, which is a complex, very complex network of actors. And in order to make things smooth, and as we develop the test, we are trying to be sure that if the work that could be implemented, ideally we should try to move on something more fluid and try to work together, like people working on research, working together from the beginning with people working on the implementation side. This includes patients, the final users, etc., and national programs, and so on. They may not be like the very knowledgeable on technology, but they will provide very useful information for us to develop the right technology, the technology that would have impact in that context. Another challenge we will need to address is the financial one. We are working on neglected tropical diseases, meaning we are working with scarce resources. According to the 2022 report by GFinder, Most of the budget for R&D was for HIV/AIDS, tuberculosis, and malaria, which is not strange for us. That's right. But if you want to look at the percentage of the budget allocated at some of the skin entities, 2% for leprosy, less than 0.1% for scabies and mycetoma, and also for Buruli ulcer. And if we take into account what is actually dedicated to diagnosis, this is much, much, much more. Okay, so less than 4% of the total funding for dedicated to R&D for neglected diseases was dedicated to diagnostics. So we are in a very difficult situation if we want to move forward. So there are many activities, many people, organizations working to improve this. And one of the exercises that was developed to help on this was the WHO Diagnostic Technical Advisory Group for Neglected Tropical Diseases. It was launched more or less around the same time of the roadmap for entities. And the idea is that this group will work supporting WHO in addressing priority areas for entities diagnosis, in identifying gaps in access to the tools that are already available, and also to advise on the innovations and developments required to ensure that the diagnostic process, as explained before, is able to properly inform decisions about the work to combat these diseases. So the WHO DTAC has a number of subgroups which are disease-specific or disease group-specific. One is the skin entities subgroups. Of course, we work with other disease groups at DTAC, but also with cross-cutting groups and activities like those related to laboratory capacity strengthening and biobanking, the subgroup on clinical diagnosis, imaging, and microscopy, those from surveillance, manufacturing, and regulatory pathways, the group on global investment and resource mobilization, and more recently with another WHO initiative, which is the Network for Artificial Intelligence on Skin Entities. Some of the activities we do, or we have done so far, and in which I think we have been very successful, because at least we have reached all the targets we set to ourselves, was the development of guidance documents together with many different stakeholders that we call the target product profiles. Target product profiles are just documents that will guide the development of these health products, in this case diagnostics, addressing the main and most urgent public health needs. The target product profiles acknowledge access, equity, and affordability as an integral part of the innovation process, and like a thing that should be bear in mind at all the different stages from concept to implementation. And these are documents which reflect WHO strategy. They reflect alignment with WHO objectives, and also try to bring together the understanding and knowledge of the companies and funding agencies. So far, we have developed target product profiles for a number of diseases, for Buruli ulcer, rapid tests that can be used at primary health care level, for leishmaniasis dermal, or this is cutaneous or post-Calasar dermal leishmaniasis, at same point of care test for confirmation of disease, for mycetoma, a rapid test for diagnosis of mycetoma at primary health care level, for leprosy, 2 rapid tests to detect active infection, and also to diagnose exposure, people that have been in contact with the mycobacteria. For scabies, another 2 target product profiles, one for starting mass drug administration, and the other to inform when to stop this process. And for yaws, a target product profile that shows the characteristics that a diagnostic test should have for identifying single case of yaws or for detecting azithromycin resistance. But besides this activity of WHO DTAC, there are other activities out there to which we should look at, and one of them is the one that has brought us to, today for discussion, which is the BU-LABNET. There are also other activities promoted recently by WHO, like these activities to empower the capacity of lab personnel on neglected tropical diseases, as well as research projects like the LAM4Os or the BioMeme PCR project supported by ANESBA, ALM, and Raúl Fulego. And I think that's it. Yeah, thanks.
Thanks, Isra, for a lovely talk. Slightly depressing with 3 separate valleys of death. My experience is it's relatively speaking quite easy to get grants that address the first 2 pieces, you know, developing a new test and showing that at least in a laboratory setting it meets performance characteristics that are required, you know, that it looks good. But we have tended to fail at really doing the implementation piece. You know, I think if you looked at the literature, there are many different borreliosa, cutaneous leishmaniasis, yaws, leprosy tests over the last 10 years. But if you look at what we are using, still overwhelmingly we are using reference laboratory qPCR. So almost a challenge to the room is, are the right people in this room? You know, most of the people in this room work predominantly in a lab setting, and what can we do to better engage, you know, the Benedicts and the Nanas earlier in the journey so that we really do end up with a test that can be implemented and will be implemented, and how can we better engage the ANESVADs, the ALMs, the other funders, so that we don't end up with another wonderful test, but no one who's prepared to pay.
Michael, I think you are right. Yeah, I mean, we still have challenges getting enough funding also to procure even the existing and known tests. So yeah, the development should go hand in hand with donors who can contribute to the procurement. Otherwise, yes, nice tests develop, but we cannot get to the patient. I think that is also a very sad situation. Yeah.
Thanks. Yeah, I agree totally with you, Michael. I think there are different things we can do. One is from the beginning, people working on developing diagnostics should be work with the end in mind. No, we should try to use this implementation research approach from the beginning. It's not just that we are working on the laboratory and we are developing tests, because, as you say, the PubMed is full of tests that work very well, but actually none of them are in use. Another thing could be donor education, if you want. So donors funding for early research on diagnostics should also try to ensure that you have a path to bring forward your diagnostic test if you succeed. And maybe it's not that donor, but consortium of donors, etc. And another aspect, I think, is that we work together, people working on this field, that we work together, try to harmonize a little bit the things. Because even in this room, I'm pretty sure there are 1, 2, 3 laboratories that have developed their own PCR test for Buruli or for leprosy or whatever. And actually, we are sitting together in this room. We should be discussing and work together towards a method which is harmonized. That way, we may be more lucky in getting funds for implementation activities. And the last, but not the least, is your question, no? All the people needed for this in this room, maybe we will need to bring other people to the meeting to help us in this aspect. No, yes, I pretty agree.
Yeah. Okay, Augustine.
I missed something. Isra, for the TPP of Mr. Thomas, did you have already finalized this TPP or not? That's the first question. The second one, the feasibility of those tests, are you in touch with some company that can assure that they can produce it? Because we at the field, on the field, we are in need. And if you show like this rapid test for Mr. Thomas, it will be a good thing, but the prealable are those two things. Is it finalized? Are there the company who are ready to produce it? Thanks.
Thanks for your question. I think if my colleague agrees, I will give the word to Wendy. I think she's in better position than me to answer.
There's a difference, of course, between a TPP and an actual test. So the TPP describes what the best test performance should be. So we described in the TPP what the characteristics of this test should be. Over time, we have developed several tests for mycetoma, but none of them are developed by companies. Some of them are in-house, and they are used in reference laboratories like the Mycetoma Research Center and our own lab. Others have been mainly developed and not used that much. But yeah, there are a few in-house tests which are used, but we didn't find any company which produces a test for us, of course.
Thank you very much, Augustine, for this important question about what is happening in the area of diagnostic at the level of the field. As Wendy mentioned that, we have a lot of projects going on right now, trying to find a test can be done at the field, friendly. Still, we're in the process of finding this test, but we have good collaboration between different institutes, Brazos Medical Center, some center in Japan, working together to find this point-of-care test which can be implemented in the future, and to contact companies. We have a contact with one company in Japan now trying to find a support for a project like this. Thank you very much.
One comment is, for the DTAG, I was just wondering, is there any inclination to support open technologies versus the closed ones, I think, in the pathway? Because looking at the sustainable diagnostic models, it would be more encouraging to look for technologies that are open than closed, so that they alternatively turn to be revenue generating models for the countries to invest into. Yeah.
Sorry. For open technologies, you mean technologies that not necessarily need like regulatory approvals, like FDA approval or CE marking, something like that? Or
well, specific to a disease like cartridge and things like that, like open technologies where you can do any type, like a PCR.
Yeah. I don't think it's DTAG, it's against that. Actually, what we are working is towards facilitating access to diagnostics, and open technologies are welcome, provided they fulfill criteria that have been develop for them. Not like, for example, I'm not very involved in that group, but the group working on surveillance or more focused in surveillance, it's of course thinking on platforms that can be open for different diseases, for example.
Yeah. Okay. Well, you can see the news. Is there anyone online wishing to intervene? Please go ahead. So, yes, go ahead.
Okay, I'd like to add that in ANESBAT we are working also with social business. So we are trying to make some loans and some company also the little companies that are trying to develop new things. And we are just now funding a little local enterprise in Nigeria that is developing a test. So that could be an idea also, no, in order to follow up with all the things that you have proposed. And I think, I mean, most of you are in the universities. You could ask also work with the university or the economical and administration university and present a little project. Because if we think in the big companies, that will be more difficult. So we have to find the ways, no, to develop this kind of test. And that could be more appropriate and ecological or whatsoever. No? So we are open to that. We are also working in social investment funds. So if there is any company that is interested in that also, we could make some contacts because I mean we are related with some of the big funds that are dedicating the money for health and Africa. So that's open.
I would like to comment, but I think it's better to speak in French to be sure that I'm really expressing what I will try after in English. So, quand on regarde le développement des tests, le rêve, nous tous, nous rêvons d'avoir sur le terrain un test le plus facile à utiliser. Mais ma question aujourd'hui, est-ce que c'est là que nous devons investir? Vu les difficultés de trouver le biomarqueur, vu les difficultés de développer le test, de le valider et de l'implémenter. Quand je regarde la présentation de Isra, il va mettre les outils en cours de développement, par exemple pour l'ulcère de Bourli, un test rapide. Et pour le peu que je sais, ce n'est pas quelque chose qu'on aura demain. On vient encore d'évaluer le test rapide avec la mycolactone et on a vu ce que ça pouvait donner. Et en même temps, parallèlement à ça, on est dans l'éradication des maladies. Donc on voit les tests, les cas qui diminuent. Est-ce qu'effectivement aujourd'hui la stratégie ne serait pas d'aller vers les plateformes ouvertes, de renforcer les capacités de programme à transférer les échantillons, parce que nous avons les tests qui marchent au niveau des laboratoires de référence, et que si ces laboratoires ont les échantillons, ils seront capables de dire quelles sont les maladies, ça se retrouve où, de décrire l'épidémiologie, d'accompagner la surveillance active et de décrire ce qui existe vraiment. Donc, c'est peut-être de dire, c'est vers là que nous devons pour l'instant mettre nos efforts, parce que sinon, développer un test rapide de l'ulcère de Bourli pour après avoir peut-être 30 cas ou 100 cas pour le pays, on n'aura pas beaucoup de personnes qui vont nous accompagner dans le développement de ce test.
I I agree with that suggestion, and not like a different line of research, but maybe as a parallel line of research, there is this approach which is diagnostic network optimization. So in the case of integration, in the case of diseases where incidence is going down, diagnostic network optimization works very well, which is basically first trying to have a very good understanding of the epidemiology of disease in the region. Second, a good understanding of the health system and the capacities at different levels. And third, just a good design of referral of materials within a network with different nodes that could be doing tests which are a little bit more complex until you reach the final reference lab if you want. So that's actually a line of research that has shown good results in other diseases, like, for example, visceral leishmaniasis, when you try to diagnose this in remote areas. In northern Kenya, there are exercises that have been very interesting, but also for other not neglected tropical diseases as well. So that's a diagnostic network optimization, another approach that can be taken for sure.
Thank you, Israel. Yes, thank you very much. Doing well with the time. We'll move on to the next presentation before lunch. So I'm going to present briefly for information purposes the skin NTD working groups, and then Sandeep will present a few slides on the one on diagnostics to take us forward. So maybe if I sit here, people cannot see me on the end. All right, so just quickly, after the March meeting, those of you who were in Geneva, we proceeded to set up some working groups in order to advance different areas of work. And I'm going to present a summary of that. Then Sandeep will follow up with me. Anyway, this is not Geneva, it's Cameroon. Last year at the BU-LABNET meeting. Again, for the information of everyone, the skin NTDs that we've been talking about, and also the roadmap targets that we have set. We've had some of them present in Ghana. There are others that we still need to know more, like Tungia and mycetoma. For scabies, I think we have a lot of scabies here. For leishmaniasis, we were in the Volta region, so there are cases in the Volta region. There may be cases elsewhere. And for the others, they are all present here. I don't want to go into the rationale for integration. I also don't want to go into the all the issues around the integration and the documents and the targets that you all have from the NTD roadmap and the skin NTD framework. Again, in different regions of WHO, there are different skin NTDs, so that is also important. And at the country level, the same thing may apply. Maybe you may not find some diseases in the northern Ghana. You may find them in the southern part of the country. So the epidemiology being solid is very important in order to also know which diseases are present, the overlap, and to target interventions. So there are about 12 working groups or so. Again, one of the issues that programs, which I didn't hear from the national program presentations, is around the other skin diseases that they see in the field and how to manage them. I think this has become a challenge for all of us because we have MDT for leprosy for free. We have azithromycin for yours for free. We have Buruli drugs. But when we see a lot of scabies, we don't have the drugs to treat scabies. We don't have the drug to treat other diseases, common fungal infections that we see. So there have been some discussions, wider discussions about the whole idea of skin diseases and how to address them, knowing that most of the skin NTDs, maximum 5 to 10% of the cases are around skin NTDs in any community you visit, but there are about 90 to 95% of other common skin diseases for which we will have to address. Again, in terms of the implementation, the focus of most of NTD work is around the district level and below. So trying to build capacity both among the health workers and the laboratory staff, and the use of any test should be adapted to the levels of the primary health care, which is the district, sub-district, and community. The national reference labs will remain specialist labs and specialist health facilities for supporting the work of the districts and the communities. So just briefly about the working groups. One is to support the implementation of the framework in different areas, to advance advocacy globally and within countries about the impact of skin NTD, gaps, opportunities, and impact on affected people. Promote research to accelerate progress towards 2030, and to foster collaboration within the NTD space and outside, and to share experiences as we are doing today. So we are moving forward with first creation of a core group, and then there is a wider group, which are the people who have signed and expressed interest to join any of the working groups. So in a nutshell, you see the core group, which will be the drivers of each working group area. And then there is a large number of people who will join in meetings by Zoom and also by email communication in order to get their inputs and to also share any progress with them. This is the consultation process. So first is the core group drafting the TOR. Then there is a sharing with all the wider group for their inputs, and then leading to finalization. And we believe that any product that is developed, the essential ones will go, if it's diagnostic, will go to the diagnostic DTAG, and then the others may go also to inform the WHO strategic and technical advisory group about any important development. And some of them may also help to feed into WHO policy and programmatic documents. This is just the list of the key leaders of the different working groups. That's why Sundeep will speak after me. He and Israel leads the diagnostic group. There are others, and we have already started with the wider consultation and Zoom meetings with some of them, work in progress. The issue of WASH remains a gap. We're trying to fill that. It's a wide area, so we wanted to focus on areas of within WASH that are relevant to the skin NTDs. Again, this is progress where we have formed a group where the TOR is developed and where the wider consultation has been done. As of, I think this data is slightly out of date, but as of the NNN meeting in last month in Tanzania, about nearly 1,200 people have signed up. This is the gender distribution. This is the geographic distribution. And then in terms of diseases of interest, I think you could see why most people are coming from the leprosy background, and there are fewer people in other areas like podoconiosis. In terms of cross-cutting areas of interest, many people are coming also from the research background, which is good. We need research to underpin the programmatic aspects. And when we look at those who registered as first option, there are 3 options. The first option is your best choice. Many people are interested in epidemiology and surveillance, diagnostics and laboratory issues, and then integration at the country level, etc. And then when we combine all the options, 3 options, we see that capacity building then overtakes the epidemiology and surveillance group. WASH, as I mentioned, our interest will be on health facility WASH to ensure that there is water for also wound care, infection control, etc., etc. So this is where we are, and I think if you would like to sign up, there is this code you can scan. And again, thank you. It's only my presentation only for information, and those who may not be aware of the working groups. If you are interested, you can also sign up. Thank you very much.
Thank you for the nice presentation. I'll just continue with the Diagnostics and Laboratory Support Working Group. Isra chairs the group and I co-chair along with him. The aim of this working group is to develop a platform of communication that provides guidance and builds capacity for research, development and implementation of priority diagnostics and effective treatment solutions for integrated management of skin entities and monitoring their impact. The reason we have included treatment solutions is that we would like the laboratory support piece merges well with the diagnostics, just the diagnostics development side. So you will see a combination of these two. The terms of reference were shared with the wider group just recently. There was quite a lot of interest, as Dr. Kingsley has just mentioned. We are yet to finalize on the core group of around 10 to 15 members. But what we thought was we'll send this to OR for the wider consultation first, get their insights, and then finalize on the core group. So as you can see, the terms of reference include, in collaboration with relevant stakeholders, we would like to work to maximize the role of diagnostics in case detection, treatment response, and case management. Review the diagnostics and drug trial landscape, which we actually introduced later in the process, just to make sure that we provide adequate guidance and support for the drug trial management in entities, in skin entities specifically. There's also a lot of inclination towards developing integrated strategies for diagnostic development, case detection, and treatment response. I would like to stress on the last point, Leish, with the WHO DTAG and other working groups to ensure coherence and synergy in the activities and minimize any duplications. So that's again something we would like to stress on, that this particular working group may not really duplicate the efforts of the DTAG, but would actually connect and work together to promote the diagnostics. Activities, this is not really finalized yet. We are still working on it. We would like to work with relevant stakeholders and identify good experts to be a part of this exercise moving forward. Analyze the diagnostic landscape, gap assessment. We would also like to align the existing technologies with the TPPs that were already published, and then sort of give an update to DTAG momentarily. Yeah. Thank you.
Okay, so thank you, Cindy. So these presentations are for information purposes, unless you have any burning question. Yes, Michael. Yes, please.
Yes, I'd just like to understand, because we're talking about using the working group to avoid duplication of effort in diagnostic development, how will the working group not duplicate the DTAG? Could you give me a concrete example of something that would be in scope of this working group that is not in scope of one of the existing DTAG groups, seeing as they already cover all of diagnostics, skin NTDs, clinical diagnosis, surveillance, and regulatory pathways?
You are right. I think it's a challenge we need to address, and that's why one of the activities for this working group, as well as many others, is to be in connection with the other activities on the same topic. But for example, one of the things in which I think in principle this is not an overlap, it will be the audience or the target number of participants in the working groups is higher than in the DTAG, which of course at the DTAG sometimes we do consultations to wider audience, but it will be like a larger group working and discussing together and bringing the discussion and conclusions to the DTAG with for alignment. No? That will, I will say, is one of the main things. And also the geographical representation of the not only the core members, but the wider group. No? Try to have more insight in that sense.
Just to add to what Isra said, the major difference, what I notice is, I think the DTAG works more on the development, the establishing the developmental pathway and things, while this working group would largely work on the implementation side, talking from the local context, the uptake. So the statement we made there as their development and implementation status, we wouldn't really talk into the development basically, but would talk into this, like review the status and make recommendations more from the local context and the context of applicability. Yeah.
If you take the DTAG, initial work was around the development of the TPPs. And the question was, if the TPPs were done, what next? But here we are also looking at the wider area of diagnostic, not only the development, but even using existing diagnostic platforms, including PCR, etc. So it may not directly duplicate what DTAG is doing, but it may also complement what DTAG is doing. And the fact that we are getting input from a wider audience will also help us to understand what's going on in different countries and on skin NTD diagnosis. Yeah. If there are no questions, we're supposed to break for lunch at 1:30 p.m.
Sorry, there are some people asking online questions about the contacts of the speakers, and I think that can be, if the speakers allow, we can share that at the end of the meeting.
Yeah, I think it's possible to share the slides after the meeting, yeah. And I believe that the Zoom is also being recorded, so there could be the Zoom link also shared with everyone, including online participants. Okay, so I think we are 30 minutes ahead of schedule, or 20 minutes. If the lunch is it's ready, then, or even if it's not ready, we can take 20 minutes of walk first before lunch. Yeah, just walk around and see the Noguchi campus. I think it's. Oh, okay. Yeah. So, well, yeah, we thank everyone for the session today and also this morning, and all those online. We will resume again at 2:30 Ghana time. So please, let's be back on time. Okay, bye-bye.
2:30 or 2? Since we are ahead of the program, so we can start at 2.
Yeah, I want people to walk a bit. It's also a medical necessity. So please walk 20 minutes before lunch, and then we have 1 hour lunch. We'll be back 2:30, yeah.